So this patient was on her Palbo and her letrozole. Um, and after 9 months, she has new asymptomatic bone lesions. So that's kind of a bummer, actually. That's 9 months of progression on CDK4/6 inhibitor. I think we really tend to worry about those patients. We certainly hope to at least get 12 months. And your average patient with endocrine sensitive disease is going to get somewhere around 22 to 24 months. But I fully agree that I would be sending ctDNA on this patient. And she has one of the canonical PIK3CA mutations. And so, because she has asymptomatic bone progression, I would try another line of endocrine therapy. Um, certainly if she had symptomatic visceral progression, I might be thinking more about chemo here, but she's got asymptomatic bone progression. She's got a targetable lesion, a targetable mutation. And so I agree. I would also choose capivasertib fulvestrant. I have to admit, I've largely abandoned alpelisib, just due to toxicity concerns with the hyperglycemia, the renal issues, the rash. And I would be talking to this patient about capivasertib. We tend to use prophylactic Zyrtec in these patients to reduce the risk of rash. We tend to also use steroid mouthwash and watch their glucose and talk to them about low carb, low sugar diet. Um, I wouldn't be excited about a BEMA. She had really quick progression, on her Palbo. And I wouldn't jump to chemo just because it's asymptomatic.
And in this patient, in this circumstance, I completely agree with how Sarah is approaching the case and really favoring capivasertib and fulvestrant here as our next line of therapy to take advantage of this actionable biomarker that we're detecting in ctDNA and the PIK3CA mutation, with the hope that targeting that alteration, we can ultimately resensitize this tumor to an endocrine therapy-based approach. If it was the PIK3CA mutation that's really driving some of the resistance that we're seeing, contributing to this shorter than we would like first-line duration on a CDK4/6 inhibitor. But if there were other features in this case, for example, symptomatic visceral metastasis, or if I think less than 6 months of benefit on a first line AI and CDK4/6 inhibitor, that is a patient that also I'm worried about intrinsic endocrine resistance that may continue to be refractory to a targeted therapy, endocrine therapy based approach, where I might start to favor thinking about cytotoxic strategies with TDXD or chemotherapy if we feel that the benefit with an endocrine therapy backbone is more limited.
I like how you broke it down there. So it's important that we remember 9 months is response. So it's not like you're super refractory, didn't respond at all patient. So, and a really important feature, as you pointed out, is that there's asymptomatic bone progression on this patient. It wasn't like the liver is blowing out of control with high transaminases. And so I think that really makes the difference in my mind. Okay, so patient is started on capivasertib and fulvestrant. Baseline metabolic screening showed a hemoglobin of A1C of 5.6, so normal. After several weeks on therapy, the fasting blood glucose is found to be about 150. Skin and GI symptoms remain well controlled. In addition to lifestyle modifications, how would you manage this patient's hyperglycemia?
Here we have a patient who was started on capivasertib therapy, and what we are detecting is an elevated fasting blood glucose relatively early on treatment, which is actually the time window that we would tend to expect to detect hyperglycemia on these therapies. And for my preferred management here, I agree with the audience. I think that continuing treatment while starting an oral anti-diabetic, likely I would start metformin in this situation, and continuing close monitoring is how I would prefer to approach this current situation. We know that with the PI3K AKT pathway inhibitors that hyperglycemia is a common side effect that we see on these medicines, and that early detection and early intervention is really key to managing those side effects and ideally preventing escalation and further complications from hyperglycemia. The baseline risk assessment in these patients is really important. Screening for prediabetes or elevated BMI can help us predict hyperglycemia risk and even implement preventative strategies at the time of initiating therapy. So things like lifestyle interventions, encouraging exercise, dietary changes, and even in some high risk patients, we could consider something like prophylactic metformin. There's data from the Metallica trial that looked at this strategy with patients getting alpelisib and showed nice results with prophylactic metformin. And monitoring on therapy is very important. So hyperglycemia in these patients often occurs early within the first month, but the median onset tends to be about 15 days. And so checking the fasting blood glucose weekly for the first few weeks, then every other week before spacing it out to checking it less frequently is important so we can catch those events early and intervene early. So coming back to thinking about this current case, we have a fasting blood glucose that is around 150 after a few weeks on treatment, which is in the diabetic range. And so I think that warrants starting metformin and talking about lifestyle changes and continuing close glucose monitoring at least twice a week to ensure that our interventions are working. With metformin, it's a medicine that we want to start low and up titrate because diarrhea can be a side effect associated with it. And so start low, go slow, and make sure that patients are tolerating it well can be really important. And I agree with continuing capivasertib here. The recommended threshold for holding capivasertib is a fasting blood glucose of over 160. So we are starting to creep up towards that threshold. But if I do need to hold drug, I like to refer to the FDA label for the specific agent because the holding parameters can vary depending on the severity of the hyperglycemia as well as the duration to get it back down towards a normal range, and can also vary from agent to agent across targeted inhibitors of this pathway. So I tend to go back to the labels if I'm actually approaching that situation with a patient in clinic.
How do you think the hyperglycemia with CAPI compares to alpelisib?
Overall, I think, at least in my clinical experience, it seems like a lot less common. I mean, we know with alpelisib, it was around a 60% rate of any grade hyperglycemia, almost 40% severe hyperglycemia. And some real world data have shown even higher rates, probably because in the clinic we're willing to treat patients with a little bit higher A1C than the very stringent criteria applied in clinical trials, especially if we're comfortable with endocrinology consultation, et cetera, and that's available to us. With CAPI, it seems to be lower, more in the kind of 15% rate. And I really commonly see the rash and the diarrhea as much bigger problems than hyperglycemia. But as Max still so nicely stated, still really important to monitor for this early.